So essentially, as we have done throughout this project, as we come into a new discussion, a new lecture, we're going to go over what we found so far. So we're using, again, the constraint package of the concepts of the philosophy of science, which is axiology, epistemology, or ontology, or usually the order I say is epistemology, ontology, axiology. The themes that we've noted are both within authors and between authors as far as what we're identifying within that constraint package. And so far it's inconsistent epistemology. So the way that knowledge is created is inconsistent within and between authors. Within some authors it's fairly consistent, but within some other authors rather, it's somewhat inconsistent, and then between authors it's somewhat inconsistent. Or maybe you could argue another way that the consistency is that they will maybe make a positivist style claim really with what would be considered constructivist type of evidence, right? So they don't necessarily do a good job staying within an appropriate constraint package. To be fair, they wouldn't have always been privy to these concepts because some of them were developed either right around the time that this work was being done or maybe somewhat after it, but they wouldn't have been disseminated far enough for everybody to be clearly aware. So there is some reason to be fair with that, but at least with our ability to look back on this work, we can make these claims. Functional anatomy and diseases, right, are behaving as ontology or the classification system for reality. So disease classifications are how we'll communicate things, but how we'll explain them, so how we'll classify things is a previously existing disease classification, but how we'll explain them is functional anatomy. Right? So that's how we're classifying, or how we're noting that osteopathic professionals from the beginning of the profession and then moving somewhat through have been classifying reality, or the way that they're classifying it so that they can interface with it. Individual empiricism and prejudice against other systems seem to remain as axiological or value-based judgments and value-based choices. So that seems consistent between all of these authors, so within the authors and between them as well. I think it's worth making note, although not written here explicitly, that there is a fair amount of making very firm claims or making very certain claims in uncertain conditions. So that again seems to be fairly consistent. So again, for consistency in the work, what we're going to do is let you know what works we're going to be drawing from. So as we're using textual analysis as the general framework for our methodology here, although this obviously isn't textual analysis in its traditional form because this is video-based or audio-visual-based and not written as a work of investigation. This isn't perfectly adhering, but that is essentially what we're pulling from textual analysis. So the major constraint of textual analysis is that the texts are purposely chosen by the person or people doing the work. So that's an axiological choice or a value judgment and a value-based choice. But we want to be clear so that you understand what we've chosen. So the books that we're going to look at now to essentially help us look at the current state of these concepts within osteopathy. So we're going to look at Foundations of Osteopathic Medicine. Why? Because it's a fairly standard textbook that is used in many parts of the world, although primarily produced by Americans. This is used in many parts of the world. The other things that we're going to use as far as texts are a few research papers, which the titles will be shown as the slides come up on the screen, so you can read those, you can look those up should you like. But we're going to use those research papers because they have been selected around the topic, right? So some of them are about the claims that osteopathy makes and how they stand up to various forms of investigation, and some of them are actually about epistemology and ontology, or really much more so about epistemology. So the first quote here from the Foundations of Osteopathic Medicine we're going to look at will essentially set the stage for some of the discussion we're going to have with respect to what's found in the Foundations of Osteopathic Medicine. There's a very straightforward thing in here that should help us understand that there can be complicated discussions, but they may not necessarily need to be complicated, and also that the things that are noted within osteopathy, at least with in the minds of some aren't fast and firm. They're just good guidelines to approach patients and patient care, right? So we're going to read and make commentary as we do so. Osteopathic philosophy, deceptively simple in its presentation, forms the basis for osteopathic medicine's distinctive approach to healthcare. Okay, so the key here, or the key in that sentence, is that it's deceptively simple in its presentation. It's fairly simple. So although the presentation is simple, it doesn't mean that there's no complexity to it, but there's a fairly simple way to go about this. So it doesn't have to be complicated, but there is complication related to it. The philosophy acts as a unifying set of ideas for the organization and application of scientific knowledge to patient care. So they're saying here that there is an overarching philosophy that helps to unify how you're going to look at things, right? So it's the philosophy, or the conceptual basis, right? So it's the way that you're going to, it's some conceptual ideas that will help you pull things together and then know what to do. Through the philosophy, this knowledge is organized in relation to all aspects of health: physical, mental, emotional, and spiritual. A patient-centered focus using health-oriented principles of patient care and unique skills, including hands-on manual diagnosis and treatment, guide the application of that knowledge. These concepts form the foundation for practicing osteopathic medicine. So just a quick note there, the idea of being patient-centered and patient-focused, that is somewhat new in the discussion that we've had so far. There is some degree to which it's already occurred within our discussions, but it's worth noting there just to pull that out. The next portion: viewpoints and attitudes arising from osteopathic principles give osteopathic physicians an important template for clinical problem solving, health restoration and maintenance, and patient education. It's a template. These are templates. These are not necessarily hard and fast. They're templates. They're ways in which you will consider things and organize information to then make appropriate choices. The details will vary, but you have a good frame, is what this claim is. In the 21st century, this viewpoint is particularly useful as practitioners from a wide variety of disciplines confront increasingly complex physical, psychological, social, ethical, and spiritual problems affecting individuals, families, and populations from a wide variety of cultures and backgrounds. So what I would say from that last piece that I would agree with is that there is more opportunity to be explicitly aware of variations in cultural backgrounds and locations of origin. That's fair. The rest of it saying that we're dealing with more complex physical, psychological, social, ethical, and spiritual problems, I don't know that I would personally agree with that, because these things have always been inherent within humanity and human life and human experience, whether you believe it's a singular reality, so kind of like a positivist reality, or a constructivist reality, or multiple realities. Regardless, I don't know that that's a particularly fair statement that I would agree with, but it is a statement that's made. So the big thing to take from here is that the foundations of osteopathic medicine is suggesting that osteopathic concepts, osteopathic principles are a good framework, but they're not necessarily specifically, at least here, claiming that these are hard and fast and that you have to do it this way. They're saying that there's a variety of ways to do it, or essentially implicitly suggesting that these guidelines, these concepts, will allow you to fill in details as needed. So a pretty straightforward question to ask, or a pretty straightforward thing to consider is, well, what are these frameworks, or what do these frameworks as suggested within the foundations of osteopathic medicine look like? Well, we'll go through these passages, fairly long set of passages, but we'll go through them and make commentary as we do so. So there's essentially 5 models in patient assessment and treatment. These 5 coordinated body functions have been referred to as 5 models, referring to the fact that they represent particular approaches to the patient. Conceptual models are perspectives by which one might view the patient. This is analogous to viewing a patient through a lens. By altering the focal length of the lens, one could view different aspects of the patient and gain various perspectives on the patient's struggle to maintain health. This would open many avenues for diagnosis, treatment, and management, including the use of palpatory diagnosis and osteopathic manipulative treatment. It is important to keep in mind that the 5 models are merely expressions of our physiological functions that maintain health and play key roles in adaptation to stressors, as well as in recovery and repair from illness and disease. So lots of words. Key point to take away, again, these are frameworks. These are not fast and hard. These are frameworks. These are ways to organize your thoughts. So these functional systems, these body systems that are related based on function, forms the basis of these 5 models. So this maps well to the concept of functional anatomy, allowing for description or explanation of what's going on with the patient. So that still seems to fit as far as the theme is concerned. The musculoskeletal system can be viewed as the core that links these 5 coordinated body functions. Figure 1.1 depicts the musculoskeletal system as the core of the hub of a 5-spoked wheel. Don't worry about that, you're not going to see the diagram here, but if should you have the book, you can look at it. But it's just a visual representation of the concept contained in these words. Careful observation and educated palpation help make the musculoskeletal system a natural entry point for both diagnosis and treatment. Importantly, the musculoskeletal system often reflects numerous signs relating to internal disease. The models provide a framework for interpreting the significance of somatic dysfunction within the context of objective and subjective clinical information. These models therefore guide the osteopathic. It gets cut off, right? So don't worry about that sentence because it gets cut off. We'll move to the next side of the slide or the next side of the image. But again, key to this being that this view of functional anatomy or anatomy as grouped by function allows for interpretation of information that's presented through both signs and through symptoms from the patient. So moving to the next slide or the next portion of the passage, the 5 model concept has been used in osteopathic postgraduate medical education or manual medicine courses for over 35 years in osteopathic manual medicine texts and in osteopathic postgraduate education journals. In 2006, the World Health Organization recognized the osteopathic 5 model concept as a unique osteopathic contribution to world healthcare. The 5 models are the biomechanical model, the respiratory circulatory model, neurological model, metabolic energy model, behavioral model. So these are all, again, groupings based on function. There are some pieces of anatomy that would share function within each one of these categories, but we're grouping things based on functional anatomy. That's the explanation. Regional anatomical approaches to the patient were presented initially in the writings of Dr. Andrew Taylor Still, MD-DO. So we're speaking mostly of ontology here, or how things are classified, how things are grouped, how you interpret information. And they're noting, at least here in this book, that it agrees with the themes that I've identified so far in this work, that Dr. Still was using essentially functional anatomy to explain things. He did eventually, in research and practice, to some degree use disease classifications or allopathic disease classifications, but he did also use functional anatomy to classify things to help you look at them. In considering osteopathic visual and palpatory structural evaluation and treatment approach to the various body regions, ECOP considered that as the muscles and joints of the trunk and extremities are primarily involved in posture and motion, addressing them would be within the perspective of the biomechanical model, addressing the costal cage and diaphragms, being that they are responsible for the movements associated with thoracic respiration and return of venous and lymph to the heart for recirculation, and are considered part of the respiratory circulatory model. Assessment and treatment of the abdominal pelvic regions represent the metabolic energy model, as this is where our internal organs that process food convert it to usable energy and discard metabolic byproducts, waste, reside. Assessing and treating the head and spinal regions represent the neurological model. Addressing the patient's lifestyle, environmental stressors, values, and choices represent the behavioral model. So again, these seem to spring from functional anatomy primarily, but what you're seeing is that you could focus your attention on a given region and then tell a different story about it related to one of these models based on functional anatomy, and then it can sound very complicated. Realistically, the same intervention, at least if you're doing the hands-on work, is occurring. You're looking for motion characteristics, change in motion, and then you apply a treatment based on that, and then based on functional anatomy that's close or proximal, you could then relate it to these other things. The symptoms that a patient would report would make you consider where to look based on these models. So this is a way to classify reality that is based on functional anatomy. So again, ontologically, or within the concept of how you classify reality, this holds true that it seems to continue to be based on functional anatomy primarily. This passage from the Foundations of Osteopathic Medicine provides some insight into how some of these concepts, with respect to the 5 models and with respect to the principles that are considered across the world as somewhat central to osteopathic practice, were generated. So we go into the quote, and again, as we go through, we will comment as is required. According to Littlejohn, the first consensus definition of osteopathy among multiple faculty members representing several osteopathic medical schools was published in 1900. After Still passed away in 1917, the AOA House of Delegates passed a resolution that the A.T. Still Research Institute, under the direction of Eliza Burns, D.O., at the time, would publish an updated version of the most popular textbook on osteopathic principles in print, adding current scientific knowledge in support of the philosophy. The book was passed around to all the osteopathic colleges for input and consensus. In 1922, this consensus-based textbook was published by the A.T. Still Research Institute as a revised edition of the classic textbook by G.D. Hewlett, initially written at the turn of the 20th century. By this time, in medical thought, it was widely accepted that the cellular activity was a strong determinant of health or disease states. In an attempt to update osteopathic philosophy in light of emergent concepts in cellular biology, the authors applied Still's mechanistic viewpoint to cellular physiology. The following passage not only illustrates this approach, but also demonstrates the desire of the profession to state osteopathic philosophy and principles in terms of concise tenets based on contemporary scientific knowledge. So, before I go into the next side of the slide and the next portion of this, just note that they took their emerging knowledge, or the new knowledge of cellular physiology, and said we need to apply our concept. Now, the osteopathic concept, or the central osteopathic concept, seems to be that there are mechanical correlates to health and disease states. So they took that concept, or they're trying to take that concept of mechanical dysfunction relating highly to health and disease states, and say that, well, these other people are noting that cellular biology is having a large impact on health and disease states, and well, we need to figure out, or we need to join that with the mechanical side. So they went about doing that. They went through a consensus process, but they said, hey, we've really got to put this mechanical idea in there. So what follows essentially is what words came out of that process. So the osteopathic view of the cell is largely covered by the following statements. Normal structure is essential to normal function. Normal function is essential if normal structure is to be maintained. Normal environment is essential to normal function and structure, though some degree of adaptation is possible for a time, even under abnormal conditions. In the human body, with its diversified functions, we may add also the blood preserves and defends the cells of the body. The nervous system unifies the body in its activities. Disease symptoms are due either to failure of the organism to meet adverse circumstances efficiently, or structural abnormalities. Rational methods of treatment are based upon an attempt to provide normal nutrition, innervation, and drainage to all tissues of the body, and these depend chiefly upon the maintenance of normal structural relations. So you can see, normal structure is essential to normal function. Normal function is essential to normal structure if normal structure is to be maintained. So that's trying to put this mechanical concept in here. They did not particularly do work that would be considered scientifically appropriate to try to disprove this concept. So the idea is that if you try to disprove your concept or disprove your hypothesis and it does not get disproven, then you have more reason to believe your hypothesis or your prediction. They didn't necessarily do that work, they just philosophically applied this. And you can see in the next few slides that we'll go through how this changed, this consensus approach changed into more condensed and more simplified statements that were able to relate to everything else. But you can see there's a few sentences in here that will ring very, very similar in the next few slides that we go through. But keeping in mind that the process here isn't go about scientifically investigating this and have your hypothesis and find a way to disprove it. And if you can't disprove it, you have more reason to believe it's true, or have faith in it, or have confidence in it, in your prediction. They said, let's just slap the philosophical concept on here, and this is the result. Essentially, the next iteration of this consensus-based process, or this process by which they were trying to come to some agreement as to how to approach the osteopathic profession, how to organize the ideas, essentially how knowledge is built. So epistemology and how reality is classified, aka ontology. They were doing this work, they were doing this consensus work. So we'll go into these quotes in just a moment, but what I want to do is also just make a quick note upon the last slide that the thing that they were doing in slapping the mechanical concept onto the cellular biology concept is what you would call essentially, it's a constructivist process, right? So they're saying the knowledge depends on us, so they just went ahead and they slapped it on. So epistemically or epistemologically, the way that they were building that knowledge was bringing their dependent truth or concept that depends on them and their viewpoint, and they were putting it into something that was created in a fairly positivistic fashion. So the cellular biology concepts would have been built by having a prediction, testing that prediction to see if they could disprove it, not disproving it, and then saying, yeah, the function of the cell or the health of the cell seems to highly relate to health and disease states. So what they did was they jumped on a positivistic thing in a constructivist way. So again, you're seeing, as far as how knowledge was built, it's take a philosophical concept that is highly dependent on your current viewpoint and trying to marry it with something else, which is not necessarily the best way to do it, because you're going to have a confused knowledge building tradition. So now that that commentary is out of the way, we'll go to this quote. The addition of medications in the practices of osteopathic physicians and surgeons over the years affected how the philosophy was stated. For example, in 1948, the faculty of the College of Osteopathic Physicians and Surgeons in Los Angeles added the following phrase to their basic osteopathic principle statement. Like a machine, the body can function efficiently only when in proper adjustment and when its chemical needs are satisfied either by food or medical substances. Further evolution occurred in 1953 when the faculty of the Kirksville College of Osteopathy and Surgery agreed on the following. So they couldn't get everybody to agree on this next set of statements, but they were trying to do it in some way. This came out of Kirksville. Osteopathy or osteopathic medicine is a philosophy, a science, and an art. Its philosophy embraces the concept of the unity of body and structure and function in health and disease. Its science includes the chemical, physical, and biological sciences related to the maintenance of health and the prevention, cure, and alleviation of disease. Its art is the application of the philosophy and the science in the practice of osteopathic medicine and surgery in all its branches and specialties. So they're taking some concepts that are somewhat mixed in how they would view reality. Art would be dependent on the individual, dependent on previous experience, so that's kind of constructivist. The science, in most cases, is probably positivistic, so a singular reality regardless of observer. They're trying to mix these things. So you're again seeing, as far as how knowledge is built, you're seeing inconsistency. You could also argue that it's a plurality, so multiple ways to approach it, but what it can often lead to when done in a somewhat haphazard way is confusion. All right, so to go back to the quote, health is based on the natural capacity of the human organism to resist and combat noxious influences in the environment and to compensate for their effects, to meet with adequate reserve the usual stresses of daily life and the occasional severe stresses imposed by extremes of the environment and activity. Disease begins when this natural capacity is reduced or when it is exceeded or overcome by noxious influences. As a fairly straightforward statement, this is what I would call kind of a no-duh thing. Well, you couldn't deal with what you were exposed to for one reason or another, so it overcame you. So either you were in a reduced state, or it was too strong for your strong state. It was stronger than you, right? So it's kind of a no-duh statement. Osteopathic medicine recognizes that many factors impair this capacity and the natural tendency toward recovery, and that among the most important of these factors are the local disturbances or lesions of the musculoskeletal system. Osteopathic medicine is therefore concerned with liberating and developing all the resources that constitute the capacity for resistance and recovery, thus recognizing the validity of the ancient observation that the physician deals with the patient as well as disease. So again, the patient is becoming a little bit more central here. Pay attention to the patient, not just the disease, right? Also, they place the musculoskeletal system at the center. So the point of focus in osteopathy is the musculoskeletal system. It's the point of entry, as was noted earlier on, in essentially a newer concept or a newer written concept. But if you center on something, then that is the thing that you're most likely going to consider. Even when it's not the actual center, you'll have a hard time identifying when it's not actually the center of something because you're already focused on it. So it's a term called a priori, or that which can be known without sensing. So within osteopathy, that which can be known without sensing is that the musculoskeletal system is the most important determinant of health and health and disease states rather. So the process that we've been outlining so far with the most recent quotes that we've looked at culminates in the 2 slides that you saw before this particular portion of the discussion, which are essentially what you would call the 4 principles of osteopathy. I tend to call them the 3 principles with 1 cop-out, right? So the first one that we'll read through is the first iteration, and the second one is the second iteration. And this all points back to a lot of that stuff that was happening in 1922. So you'll see some of the simplification and kind of bringing together in a smaller way. And this, if I remember appropriately, all came out of the Kirksville College of Osteopathic Medicine and Surgery, I believe was what it was termed at the time in '53. So the first quote here, the osteopathic concept emphasizes 4 general principles from which are derived an ideological concept, a philosophy, and therapeutic technique that are distinctive, but not the only features of osteopathic diagnosis and treatment. So the ideological concept, the causative concept, the concept that causes disease. So the 4 here, the body is a unit, the body possesses self-regulatory mechanisms, structure and function are reciprocally interrelated. Rational therapy is based upon an understanding of body unity, self-regulatory mechanisms, and the interrelationship of structure and function, right? So the 4th one being rational treatment is based on the above 3. That's what I call the cop-out. The 3 others are essentially uniting concepts that would help you organize knowledge. So the next one, which is essentially a second iteration of it, the body is a unit, the person is a unit of body, mind, and spirit. So they adjusted that first one a little bit. 2, the body is capable of self-regulation, self-healing, and health maintenance. 3, structure and function are reciprocally interrelated. So one can influence the other. So you could make the chicken and egg discussion occur here. So which one started it? Was it the structure? Was it the function? Was it the function? Was it the structure? But what they say is that they're reciprocally interrelated. So that helps you organize your thoughts and gives you some reason to say, well, I can't necessarily get to the function, but I can get to the structure. So I'll do what I can to the structure, and it should have an impact on the function, is the concept that you would derive from this if you happen to agree with it. 4, rational treatment is based upon an understanding of the basic principles of body unity, self-regulation, and the interrelationship of structure and function. So that's the cop-out again. Rational treatment is based on the above 3 concepts. So having gone through the quotes from the Foundations of Osteopathic Medicine and noting that functional anatomy is still an important ontological or classification of reality concept, and that it is the functional anatomy that essentially generates the concept of the principles, those 4 principles or the 3 principles in 1 cop-out, and that the way that some of the osteopathic concept was developed was by taking the central concept that the musculoskeletal system is the point of focus, or the main point of focus, as well that there are mechanical correlates to health and disease states, and then smacking that onto the observations from a positivist point of view from cellular biology, saying that cellular biology or cellular function has an impact on health and disease states. So doing that in a philosophical way and saying, well, we'll just add this in so it'll help us continue on and be concise and up to date without doing the appropriate work that would help match the claims of the cellular biology. We see some of the progress of how osteopathic knowledge was developed, so epistemic, the process of epistemology, as well as ontology, so functional anatomy being central. We now take a look at a research paper that actually asks the question, essentially, what are epistemic cultures within osteopathy? This was done in the Australian context, and it included members of traditional Chinese medicine in the same Australian university, and it was able to compare and contrast them. Obviously, we're going to focus more on what was said about the osteopathic practitioners, but we'll go through the abstract because it'll give us a general idea. There is increasing pressure on complementary and alternative medicine to follow the evidence-based approach promoting an allied health and medicine, in which randomized controlled trial represents the evidence gold standard. So that is an epistemic thing. How do you build knowledge? So they're saying there's increasing pressure. So to translate this into our constraint package, there's increasing pressure to be more positivistic than constructivist. So pay more attention to things that can be identified regardless of who's looking, and pay less attention to those things that depend on the individual practitioner or the individual patient. However, many CAM advocates see those methods as undermining the holism of CAM practice, so they want to use a different epistemology or a different kind of approach. Right? So there's a bit of tension here between how knowledge would be built and how reality would be viewed. This paper explores how such tensions are managed in CAM university departments, settings in which particular forms of knowledge and evidence are given official imprimatur by CAM educators and researchers. By comparing two types of CAM, the paper also unpacks differences with this broad-based category, asking whether CAM academic disciplines comprise different epistemic cultures. Epistemic cultures, how the sciences make knowledge. That's the part of the reference, so please excuse that. Don't worry about that. Interviews were conducted with 20 lecturers, so this is a constructivist approach, a qualitative. They interviewed people and asked them what they thought. With 20 lectures in Chinese medicine and osteopathy across 5 Australian universities, and augmented with observation in 2 degree programs. Findings reveal contrasting ontological and epistemological perspectives in the 2 academic fields. Chinese medicine lecturers had largely adopted bioscientific models of research, typically conducting laboratory work and trials, although teaching included traditional theories. Osteopathy academics were more critical of dominant approaches and were focused on reframing notions of evidence to account for experiences, some advocating qualitative research. Right, so what that notes is that, at least when comparing and contrasting in the Australian context, traditional Chinese medicine in universities and osteopathy in universities, the traditional Chinese medicine lecturers and the people within those departments were adopting a more bioscientific model, as is the claim or the term used, so they were maybe shifting over to a more positivistic approach. And they were still including the older concepts, but they were mapping them on to a more positivist-based approach, whereas the osteopathic practitioners, the osteopathic lecturers, were advocating more patient-focused, more experience-focused, which is essentially a call for constructivism, or knowledge being built based on the individual, the previous experiences of the individual, and the environment of observation. So being more constructivist and more qualitative. They were essentially resisting being a positivist. If you get into the kind of the meat of the paper, they actually essentially would note, and this isn't the same within all of the people that they interviewed, but it is somewhat consistent as a theme, that they don't pay as much attention to biomechanical findings. They pay more attention to the experience of the patient. So the patient experience and the experience of the practitioner are being held as more important as far as how you view reality and how you classify or build knowledge. There is less emphasis by these individuals, or the people interviewed here, based on those things which would be consistent regardless of who was looking. So they prefer constructivism is the main claim here, the main finding within this particular piece of research. So the patient, again, being more centered, the experience being more centered than maybe a measurable outcome. So we look at 2 meta-analyses. So meta-analysis is essentially research about research. You take a bunch of research, you have some constraints on how you do that. There are very particular approaches in some cases, and then you look for papers and you bring them in. So if they hit your inclusion criteria, you use them. If they don't, you exclude them, so there's your exclusion criteria. And you try to answer a particular question based on research that already exists out there. So you do research on research. Now, when doing research on research about osteopathy, specifically, at least what we're going to note here, is cranial osteopathy and visceral osteopathy, the question was reliability of diagnosis and clinical efficacy of cranial osteopathy as well as of visceral osteopathy. These are essentially being done in a positivist way. There is a singular reality that could be identified regardless of observer. So this is a positivist viewpoint. When using a positivist viewpoint, the claims made by both cranial osteopathy and visceral osteopathy, essentially there is no reliability or clinical efficacy based on the claims. So you have to be very careful with how you read this, because it's not, in some ways it is an indictment of the cranial concept and the visceral concept, but what you need to understand is how the epistemology is generated, how they view reality. They view a singular reality. The way that systematic reviews are done, it's a singular reality. You're trying to answer a particular question with constraints. How the knowledge is built is, do these hit certain criteria? Can we trust them? So reliability as a term is essentially, can I expect to have the same range of outcomes, right? So again, same range of outcomes regardless of where this is done. So that's a positivist viewpoint. This should be consistent regardless of who does it or where it's done. And when you ask that question, and then how clinically efficacious these two systems are based on their claims, there's essentially nothing there, right? Does that automatically mean that nothing's happening? No, it doesn't. It means it could mean that something's happening. It's just when you ask that question, those things aren't there. So here's where we have the tension between epistemologies, because the common claim in cranial or visceral osteopathy will simply be it works for the patient notes something positive. So you're basing your ontology, your view of reality, on the patient experience. You're basing your epistemology or knowledge building based on the patient experience. If you build them on patient experience, you can then gather information to say there's a positive impact on the patient experience. But if you then make the claim that it's having a positive benefit on the patient clinically, so with blood markers or with motion markers or with any of that, they are not going to cross over well. So cranial osteopathy and visceral osteopathy can be argued to live mostly in a constructivist world. They value experience over objective measures. So if you measured them there, you'd find something. But if you measure them on clinical measures, so reliability, so consistency in application, consistency of outcome, there's nothing there, right? So you need to understand how knowledge is built to understand where the tension between science and osteopathy, or a positivist approach to science and osteopathy, are living. Because there is a tension, there is a problem, and we can see it in studies like this. You ask a positivist question of osteopathic research, and you find nothing. If you asked a constructivist question, you may find something. We don't necessarily know what you'd find, but you'd find something. But the claims that are being made by osteopathic practitioners within cranial and visceral fields, they're making very certain claims in uncertain circumstances. So they're making positivist claims, but they're using constructivist methods to inform themselves. So they're highly certain based on their experience that something's happening, but when they measure the thing that they're certain is happening, it's not. So they're using different knowledge construction methods, which creates this tension and which creates this problem. So to help illustrate some of where this tension builds, I'll give you something that's a research paper about cranial, right? So it's not necessarily primary source research in this case. Would really be considered more of like a narrative review, or a review that depends on the individual writing it and their previous expertise. There's no proper search pattern here. It's just these people know some stuff and they wrote some stuff down. So they would consider themselves cutting edge, and that's what they're sharing with you. So we'll read this and then comment again as we go. The concept of cranial osteopathy was introduced by W.G. Sutherland, D.O., and became the foundation for setting the rules for use of skull palpation and many other techniques in the many types of dysfunctional patterns that craniosacral therapy treats. So they told you where the knowledge came from. It came from one person and their experience and their knowledge and what they shared, and then it became the foundation for laying how you touch a skull. You may agree with that, you may disagree with that, but that's a constructivist, not knowledge building method. That is not a positivist knowledge building method. That method, it completely depends on Sutherland and then how you interpret Sutherland, or how Sutherland has been interpreted before you at the time that it gets to you, right? So there's a lot of interpretation there. And that interpretation could be like a broken telephone, or it could be a perfect line of transmission. Arguments are able to be made about those things, but it is not something that will create reliability. It is not a consistent method that will allow you to have consistent results regardless of who does it or regardless of where it's done. It will allow you to have very individual results. Okay, so we go back into the quote. The mechanism, Sutherland's theories enabled modern osteopathy to develop and improve. So that's a claim that has the underlying assumption that what Sutherland said did actually create improvement. There's no way to judge that claim based on what's said here, because you've provided no proof, or you've provided no attempt to disprove that. So there's nothing there. It's just something that they said. Fine enough, because this is a narrative review, so it doesn't have to meet a different level of rigor. But that's a big claim with the underlying assumption that Sutherland did do something and that it was an improvement. You don't have a pre and post measurement, so calling it improvement, probably not the most fair thing to do, but it is something that was done. Also, just a brief note on the concept of theory. A theory, in a strict technical sense, is a prediction or hypothesis that was attempted to be disproved many times and has not been disproved. Therefore, it is as close to reality as we can get, or objective, or obligate reality as you can get, because you try to disprove it over and over again, and it doesn't get disproved, and it predicts the range of results very accurately. If you call it a theory, and it was just something somebody made up because they saw a bunch of anatomy, in the case of Sutherland, he thought some ideas, like the gills of a fish, its respiration, and this, that, and the other, then what you get is, it's not a theory, it's still a prediction, it's still a hypothesis. It doesn't, in a technical sense, deserve the term theory, but it does have it. It is common parlance, it's colloquial. You can make the argument that because of those things that you can use it that way, but in a strict technical sense, Sutherland has no theory. He has a prediction, and his prediction has not held up to scrutiny, and that's what you saw with the previous meta-analysis. Anyways, to get back to this quote, the mechanism of primary respiration, as well as the motion of neurocranial and viscerocranial sutures, are phenomena intrinsic to the field and can be found in every living organism, independent of thoracic breathing and cardiac impulse. So again, a big claim. You can find it everywhere, regardless of what they are. You can find it everywhere. Big claim. Not necessarily supported, especially if you look into the meat of the paper, or if it is supported, it's not supported in a way that most people examining this would be comfortable with. The sphenobasilar synchondrosis, i.e. the joint between the base of the occiput and the body of the sphenoid bone, is the pillar supporting the concepts of craniosacral therapy. This article compares the cranial model devised by Sutherland with the present relevant scientific research aiming at clarifying the possibility of applying craniosacral method in the new millennium. So what I will say again is, if you read through this paper and you understand positivist methodologies, they're making positivist claims, but they're drawing on research that does not have high quality positivist methodology. Their claims are not as well supported as this would like you to believe. The sphenobasilar synchondrosis, modern anatomical study would suggest that, I believe it's by the time people are about 15 years old, and I may be off on the age, but it's not a synchondrosis anymore. It's fused. It doesn't move in most adults. There may be some adults where the joint is still patent, or aka it can move, but for the most part it is not mobile. Once you're beyond the age of 15, again, I may be wrong on that age, but that is modern anatomical understanding, because we've had enough time to have enough images, and not just make it up in our heads, but we have enough proof, so enough cadavers, enough images, enough MRIs, enough x-rays, enough varying forms of testing to know that beyond a certain age, it is not a joint. It is absolutely fused. It does not move in the way that you would have to believe it to move to believe that this craniosacral method, that cranial methods, or the sphenobasilar concept actually has a meaning. Because if you look at positivist methods that are up to date, there is no way that this concept can apply, because the joint simply isn't patent. So they're trying to build a case for, using research in a narrative sense, in a narrative review sense that is based on the expertise of the individuals writing it. So it doesn't stand up to positivistic rigor. It can, but it usually doesn't. And in this case, it doesn't. So they're making a bunch of claims saying, yeah, it's still awesome. But they're mixing epistemologies, or they're not using positivism well. So now we compare what we noted in the previous narrative review to the two slides that you just saw and that we'll read through. Now, what you need to know about the article that I'm pulling from here is that it is not a narrative review, it's a commentary. So it's a commentary based on cranial osteopathy. So Steve E. Hartman says cranial osteopathy, its fate seems clear. So this is a longer article that most people can find and I think get the full text. But what we want to do is walk through here. I'm going to show you what he's doing. So although it is a commentary and doesn't necessarily hit positivist levels of rigor, he does do what would be considered good positivist behavior, or good behavior of somebody who believes there's a singular reality that can be found through appropriate experimentation regardless of who's looking. Right? So keep that in mind as I read through this. Over the years, in both formal, e.g. classroom, and informal, e.g. clinical settings, ever more students and practitioners learn Sutherland's or Upledge's related mechanism and abundant anecdotal success with patients. So he gives you a a reference there, so you'd have to look at the reference section, but you'd be able to find it should you be looking, right? Then patients were healed, careers were established, and all was good. Then reality weighed in. 1, as an underlying rationale, the primary respiratory mechanism, including Upledger's craniosacral adaptation, has failed utterly. Provides a reference there, good positivistic behavior. He points to it. Right now, the other article did point to research. It just pointed to research that, again, upon examination, doesn't hold up as well. Evidence and biological common sense entirely invalidate Sutherland's mechanism. 2 references there. Diagnoses based on the mechanism feature not just lower reliability, but no reliability. So there's no consistency, right? So this completely depends on the individual. In application, reliability, again, meaning that regardless of who does it or where it's done, you'll have a consistent range of outcomes. There is no evidence whatsoever that different practitioners perceive similar phenomena or even that perceived phenomena are real, right? After most of a century, no successful, properly controlled outcome analyses have been published. Practitioners have no scientific evidence that their therapeutic actions, however grounded in biology or metaphysics, have any direct effect on patient health. So there's no health marker that shows the claims of these practitioners to be what they say they are. It doesn't mean nothing's happening. It just means they're building their knowledge in a constructivist way based on the individual, based on their experience, right? So this is not something that would be true regardless of who does it. Now, you can then make the argument, well, I'm awesome, so that's why it works, and you're not as awesome as me, that's why you can't get it to be done. That's not the same claim as saying it's awesome. You're saying I'm awesome. If you're saying it's awesome, if you say cranial osteopathy or visceral osteopathy is awesome, then you need to show that everybody can do it. If you're showing that you can do it, that might show you're awesome, but it might not, right? That's hard to disprove. So we move on to the next portion of this article. So, question is the end. Well, it should be, but it's not. The therapeutic administrations of many cranial practitioners derive directly from the now invalidated anomalous primary respiratory mechanism. This means that up-to-date practitioners no longer even have the imaginary biology of Sutherland's mechanism to explain what they do or why they believe it works. Some clinicians of my own College of Osteopathic Medicine disavow intellectual allegiance to the mechanisms, but cling to it as a teaching metaphor because they otherwise lack even this failed biological device to unify and explain their diagnostic and therapeutic propositions. Some counter criticisms by changing the subject to a perceived array of poorly understood conventional treatments. So they just say, well, we don't know why that works. So they just kind of say, hey, look over there. Don't look at me, look over there, is what he's claiming. And that's personal, so that's actually a constructivist claim. He's a good positivist, but he does do some constructivist things in here. We want to be clear about that. Many deflect criticism by instead focusing on, personal clinical successes. So again, the people who are claiming cranial is good, he is personally claiming they're talking about they're awesome. Not it's awesome, but they're awesome. So personal clinical success. Many practitioners around the world disown Sutherland's biology-based mechanism altogether or were trained in a somewhat different model and instead engage objectively immeasurable body energies, quantum mechanics, vitalism, or God, right? So they'll just make different claims. They're trying to explain it in some way, shape, or form. But again, this is cranial and visceral. The claims of cranial and visceral are primarily generated by the individuals who believe they're having success, so it's constructivist, and they focus on patient experience. In focusing on patient experience, they then believe that they're noticing something consistent because it's them and it's through their lens. Then they make a claim, like a positivist type claim, but it doesn't pan out. So you're again seeing that in osteopathy, at least 2 popular forms of osteopathic approach in cranial and visceral are constructivist in their nature, in their application, and their learning. They make positivist claims, so they make highly certain claims in uncertain circumstances, and they're not correct in the claims that they make. Again, there may be something that's happening that's very valuable on the experience side for the patient, but there is no reason to believe that it is the thing that the practitioners say that it is. There may be something positive, may be something good for the patient and their experience, but on a functional anatomy level, it's really not doing anything that's notable. There's nothing measurable, there's nothing that can be noticed time and time and time again. So you have, again, that feature or that theme of highly certain claims in uncertain conditions, and then when you test it out in the appropriate epistemology, it doesn't really pan out. So we again see this tension over and over again within the profession. It was there at the beginning, it stayed, and this is the state that we end up in. So what we do now is essentially consider what has occurred by looking through these purposely selected texts and looking at how osteopathy creates knowledge. So the foundations of osteopathic medicine essentially would suggest that knowledge is created based on functional anatomy. Ontology is essentially how you're going to interpret it or how you're going to classify it, so functional anatomy is extremely important. The foundations of osteopathic medicine, one of the most important texts used around the world, is saying knowledge is created this way. We did see within that there was the attempt to apply the mechanical correlates to health and disease states to the cellular biology concept of health and disease states, or correlates to health and disease states, so they just kind of philosophically married them. One was generated in fairly positivist ways, one was generated in constructivist ways, and they just did this. So we have an inconsistent knowledge building approach. We do have functional anatomies consistent, so we then look at the cranial concept and the visceral concept. Well, those are constructivist in how they're applied, how they're learned. If you try to get those to match up with positivism, they don't do it well, right? So they're taking a concept and they're making claims about it, making highly certain claims about uncertain things or in uncertain circumstances, and then when they test them, they don't match up well. I have seen evidence of elderly COPD patients receiving osteopathic treatment, and then they measured air trapping. So they did a personal experience measure, which was how do you feel, what do you think, and then they did an air trapping measure. Essentially, I believe it was at the half-hour mark, all air trapping measures were worse after osteopathic treatment. So objectively, on a measurable biological phenomenon, all measures were worse at the 30-minute mark, but all of the patients essentially reported that they felt good, they felt better. So patient experience and objective measures don't always match up. One can be good and one can be bad. And it can go the other way. So objectively, a patient can be moving better, but they don't like the way they feel. So they could move better and feel worse. So these things, the objective and the subjective, don't have to match. But what we have in osteopathy is a long line of using different epistemologies, or maybe using one epistemology, a constructivist epistemology primarily, and then making positivist claims, and they don't match up. We've had enough time to test whether they match up or not, and they don't. So the theme still holds. The epistemology is still inconsistent. The ontology does have a slightly new element. It was there at the beginning of the profession, because I do have memories of Dr. Still and Ernest Tucker essentially making mention of, understand that that's a human under your hands, it's a person, so pay attention to the person, right? But we have an element of the patient experience. So the patient experience makes osteopathic practitioners seem more constructivist. They're more concerned about the experience than the measurable biological or biomechanical outcome, as well as other intangibles. So things like energy fields do show up. Now, that doesn't mean it shows up everywhere. It means it shows up in what we've examined. So we've examined something with respect to cranial osteopathy and visceral osteopathy, so you're more likely to see energy claims there. You may not see them in other places, but within what we've looked at, those have shown themselves. So intangibles alongside functional anatomy as the individual empiricism claims fall apart. The reason I say that the individual empiricism claims fall apart is because the constructivist people within varying methodologies, now this would probably hold true, or you could predict it would hold true within other parts of osteopathy that we didn't look at here, but in the realm of cranial and visceral osteopathy, they make individual empiricism based claims. So I saw this is what I know, this is what it does, and then when you test them, it doesn't hold up to the claim. So it makes the joint move, it makes the sphenobasilar joint move. You test the sphenobasilar joint, well, if they're beyond a certain age, it's not a joint, it doesn't move. And even if they are below the age where it would be still patent, it doesn't really move the way that they say it moves. So it's not doing the thing that they say it's doing. So that individual empiricism falls apart when you're trying to make a claim in one epistemology. So you're trying to make a positivist claim, this is true regardless of who looks, but you're basing it on personal experience, you're basing it on constructivism. So that is starting to fall apart, which is where we live today within the profession. The axiology does seem to be shifting over time to the patient experience. That's based on the ontological, or the view of reality, the classification of reality, that they prefer the patient experience, or trying to classify, or osteopathic professionals are seeming to classify based on patient experience more, measurable things less over time. They still center functional anatomy, and they still center the musculoskeletal system, as we saw in Foundations of Osteopathic Medicine. They center it in their discussions and their viewpoints and how they're going to interpret stuff. But when you actually ask the practitioners, and this isn't a large amount of practitioners, and this isn't practitioners all over the world that I'm citing, this is people in Australia, particularly in the university system. So it doesn't, what I'm saying here doesn't mean this is true everywhere. It means that within what we've examined, this is what we found. That they do seem to be paying less attention to functional anatomy or change in functional anatomy. They're still using it, but their preference for how they're judging things is the patient experience. Did the patient like it, right? So you're trying to do things that the patient likes as opposed to trying to do things that may be clinically relevant for the patient based on signs. You're working on symptoms more than signs when you base it on the patient experience, unless the patient experience is primarily based on signs, but it's a variable thing at that point. So keeping in mind that signs are things that anybody can identify, including the patient. Symptoms are things that only the patient can identify. So what the patient tells you is what you focus on. If the patient tells you to focus on the fact that their shoulder can't move, and you do that, then again, the patient experience is centered, but you are at least working on a sign at that point. When the patient says my shoulder hurts and their shoulder moves very well, but then you're trying to make their shoulder feel better, you're not using the sign, you're using the symptom. So it's a variable thing there, but axiologically the value judgment is the patient experience seems to be more important than the individual empiricism, which is still important, but maybe a little bit less so and a little bit less centered from what we've examined. And there's from what we've examined, there's less talk about the fact that they're looking at the things that they looked at in the past. So shifting to the patient experience away from individual empiricism, and they're also talking less about prejudice against other professions. They're, I think, accepting more so that the other professions have their value and have their place, at least in what we've examined. So they're not saying that doctors suck and osteopaths rule. They're not saying homeopath sucks and osteopaths rule. They're just saying osteopaths do this. So they're focusing a little bit more on themselves and being a little bit less prejudiced to other healthcare practices.